Well, let's get started. I just want to give you all a warm welcome from the United Nations Institute of Training and Research and the Global Surgery Foundation and the co-sponsors of this event in the NSOAP implementation series, which the Program in Global Surgery and Social Change from Harvard Medical School, Johnson & Johnson, and the G4 Alliance are the co-hosts of this series. And we're very pleased to have two excellent moderators. The first one, I'd like to introduce Dr. Laura Hamake, who is a global health consultant and a board member of the G4 Alliance, and also Isioma, Isioma Okolo, who is one of the fellows at the PGSSC at Harvard University. So without any further ado, I'd like to turn it over to Isioma and Laura. Thank you very much. And I really look forward to a great session today.
Thank you so much, Jeff. Welcome to everyone, and welcome to really kind of the backbone as we think about global surgical care. Just to remind us, 5 years ago, the Lancet Commission on Global Surgery really made the case for investing in surgical services and showed that, around the world, more than 30 million people are impoverished because they can't access surgical and anesthesia care. And out-of-pocket costs are enormous. More than 70% of the world's population does not have access to safe, affordable surgical care. And we know that for every dollar invested in surgical care, we can generate an estimated $10, for example, in economic productivity. But untreated surgical conditions will cost the world probably more than $20 million between 2015 and 2030. And the poor countries, low and middle income countries, are hit hardest. About 2% of their GDP can be lost because they can't access surgery. We've had a series of webinars really digging into what it takes to develop a national surgical obstetric and anesthesia plan, which today we'll be calling NSOAP. So remember that acronym. But again, without resources to finance it, a plan is just a document. So today we're really going to be digging into what it takes for countries to develop a financing strategy and how we can think more creatively about putting together the funding needed to address surgical care. But within the NSOAP process, we need to make sure that we start with what's available at the country level. Is NSOAP really integrated into the national budgeting process? The ministries of health, finance, and other partners really need to be involved. And it's all about really building an investment case. As we know, funders, private sector, we're all getting smarter about what we invest in, and we want that return on investment. So this is really at the country level about mobilizing that political support. So again, just a reminder from the Lancet Commission, it's not other global health issues or surgery. We really have the data that shows that building a strong surgical system is really about building a strong, resilient health system. And as we've seen during the COVID outbreak, there's been a lot of investment in responding to COVID, but also part of that investment really has to be developing the surgical and anesthesia capacity at the country level. Surgery can help, a surgical system can help countries better respond to an outbreak like COVID. Surgery is part of those critical care systems that we've seen are really necessary in a pandemic like COVID. They can contribute to improved pandemic response and also to global health security so that the world is ready for the next outbreak, the next pandemic. Next. So again, today we're going to be talking about a lot of different options, and I hope everyone participating in this really thinks that it's not money set aside for surgery, but it's how do we integrate it and really build it in the fiscal space for global health and for public health in general. So touching on domestic resource mobilization, what can low and middle income countries do themselves to create that fiscal space and make their own investment case for investing in surgical systems? What do other governments do? What is overseas development assistance? What's the role of governments from other countries in funding surgical systems think about some global health initiatives like Gavi, the Global Fund, Global Financing Facility at the World Bank. What's their role in supporting surgical systems? Foundations, corporate philanthropy, and thinking the transition kind of from corporate philanthropy to private sector investments, which we'll be touching on today. And then we're also going to talk about the role of the Global Surgery Foundation and hopefully helping to coordinate a lot of the funding discussions. So now I'll turn it over to Dr. Isioma. Thanks.
Thank you very much for that, Laura, for setting the scene. And I'm delighted and honored to be co-moderating this panel of distinguished and diverse experts in their chosen fields. So we hope to bring out different perspectives on this very common rate limiting step with regards to the funding and the scale up of surgical systems from a government, corporate philanthropy, development finance institution, and industry perspective. So first of all, we have Ambassador Jimmy Kolker providing the government perspective. So Ambassador Kolker previously worked with the Assistant Secretary for Global Affairs at the US Department of Health and Human Services. He has a 30-year diplomatic career with the US Department of State, where he served as the US Ambassador to Burkina Faso and Uganda. From 2005 to 2007, he was the Deputy US Global AIDS Coordinator, leading the implementation of the President's Emergency Plan for AIDS Relief, PEPFAR, as we commonly know it. He's now retired, but Ambassador Kolker serves on boards of Mana Nutrition, the G4 Global Surgery Alliance, Building Tomorrow, and Firelight Foundation. Welcome, Ambassador Kolker. Next, we have Ms. Poppy Sidra, who is today providing a corporate philanthropy perspective. So Ms. Sidra is the India Directive of MSD for Mothers. MSD for Mothers, also known as Merck for Mothers, is a $500 million 10-year initiative to tackle maternal mortality through grants and impact investments across the world. Ms. Sidra has 2 decades of experience working in healthcare and financial sector solutions in India, and is a strong advocate for using market-based approaches to tackle social challenges. Since 2017, she has been engaged with FOXI, which is the Federation of Obstetrics and Gynecological Societies in India, for the conceptualization and rollout of the national scale of the Manyata program, which we will be hopefully hearing more about later in our discussions. Very warm welcome to you, Ms. Sidra. Next, we have Mr. Shantakumar Banichelvam, who will be providing a social impact investing perspective today. So Shantakumar is the managing partner of Global Impact Partners, an impact investment advisory firm working with asset owners managing well over $100 billion US. Shantakumar led the development of the Global Health Impact Partnership, which is a platform to invest $1 billion into healthcare outcomes-based financing. He's the co-author of the Global Steering Group on Impact Investment, and he has previously worked in corporate law at Herbert Smith Freehills and at the United Nations Economic and Social Council. Very well, welcome. Next, we have Mr. Daryl Dong, who will be providing a development finance institution perspective today. Mr. Daryl Dong is a senior business development manager at the International Finance Corporation, IFC, a sister organization of the World Bank and member of the World Bank Group. And as we know, the largest global development institution focused on the private sector in developing countries. The Bank Group has set 2 goals for the world to achieve by 2030, which is to end extreme poverty and promote shared prosperity in every country. To create markets in target countries and sectors, Mr. Dong, principal financial specialist, structures projects and transactions to drive impact and support growth of IFC clients. Very welcome, Mr. Dong. Next, we have Mr. Ian Walker, who will be providing a corporate industry perspective. Mr. Walker is the managing director at Johnson & Johnson. He is the global program lead for the essential surgery program at Johnson & Johnson and a senior director within the Johnson & Johnson Global Community Impact Team. And he guides the company's strategy and execution in the area of social business practice, mainly in EMEA and Asia Pacific. The Global Community Impacts team has been tasked with supporting and championing people on the front lines who are at the heart of delivering care. Mr. Walker is also a member of the UK's Johnson & Johnson Medical Limited Statutory Board of Directors, and he is particularly interested in the area of obstetric fistula prevention and repair, and surgical capacity building. As mentioned earlier on, Johnson & Johnson are kindly sponsoring this event. Very welcome, Mr. Walker. And last but not the least, a very familiar face, we have Dr. Jeff Ebertson, who is the executive lead for the Global Surgery Foundation, hosted by the United Nations Institute for Training and Research, UNITAR, where he is also a senior health advisor to programs in health and development. He has more than 25 years of experience in medical, humanitarian, and disaster relief work, during which he has served as a frontline surgeon in multiple countries and in several conflict zones. He has led disaster response activities, developed strategic programs, and guided organizational and governance reviews and restructuring. Very warm welcome. So very warm welcome to all of you. Now we will open up the floor and ask each of our panelists to give further introductory remarks with regards to your background and perspectives on funding surgical systems. Over to you, Laura.
Thank you, Isioma. As you see, we have a great panel, and we look forward to a lot of discussion among us, but also to answering questions from the audience, which are already starting to come in. So Ambassador Kolker, would love to hear from you about how governments prioritize funding allocations and kind of the role of overseas development assistance in surgical funding. Thanks.
Sure. Thanks, Laura and Isi and Jeff and Johnson & Johnson for helping to organize this, all the sponsors. As you heard, I was a diplomat for many years who morphed into this global health policy person. And I was sitting in the chair for the United States in 2015 when the World Health Assembly adopted the resolution about surgery and especially mandating that countries have national surgical obstetric anesthesiology plans. But one thing many people don't understand about WHO, World Health Organization, is that it has huge mandates, but almost no funds. And those funds are even more stretched than ever now. And so there was no particular fund available to countries to develop, let alone implement the national surgery NSOAP plans. And bilateral donors remain the largest source of international assistance for global health. Like USAID, British, European, and other donors are the main partners for many low and middle income countries in terms of international assistance for global health. And there's no donor who has made surgery a particular high priority of its own assistance program, but there are huge overlaps with priorities that are already established by organizations such as the U.S. Agency for International Development. For instance, in maternal and child health, even fistula care, human resources for health and workforce. So taking advantage of these existing programs and seeing how they apply to surgery, obstetrics, and anesthesiology plans is certainly a good place to start in looking for existing assistance. Since 2015, the Sustainable Development Goals, the COVID outbreak, the further recognized need for universal health coverage have all reinforced the need to be sure that surgery and anesthesiology are part of national strategies and that we have those capacities in the need to surge no matter what the health threat is. But they've also emphasized how important stakeholders are, that national plans, the Ministry of Health does need to be the author and the owner, but that in order to succeed, the private sector, non-government organizations, faith-based organizations, providers, patients, all need to be represented and see themselves in that plan. And so the role of civil society is and stakeholders is highly recognized in the manual that has been developed for NSOAPs, which I recommend highly. It's really a well-done book by UNITAR and a number of partners in looking at how to set up a plan and who needs to be at the table. But as we also know, the funds through bilateral donors and existing programs are simply not going to be enough. And innovative financing mechanisms, which you'll hear more about from some other speakers, are going to be key if we're going to succeed in this. And the pooled funds have the advantage of putting countries in the driver's seat. If it's a donor financed program, the donor's priorities often restrict a great deal what a country can apply for or to whom the funds go. A pooled funding mechanism allows for national plans like the Global Fund plans for AIDS, TB, and malaria that require a multi-stakeholder approach and require a more holistic view of what the program is supposed to accomplish, who its beneficiaries and its owners are. But it's also important, as the manual does, to emphasize that the means to the end, as well as the end itself, need to be domestic. The domestic financing is the integral part of health system strengthening and of universal health coverage. And I saw the first question already was about political will, and so I'm going to just jump on that. Political will isn't a light switch that you can turn on and off. Political will is something that needs to be built up by the process of developing an NSOAP and by the process of implementing it, such that we're using data and evidence, we're making sure that advocacy organizations are fully aboard, that we look at partners beyond the scope of the usual health advocates or health practitioners in the country. And that political will is something that means that the government itself sees this as its priority, and that they recognize that the capacity in the country to achieve this is feasible. This is not something they have to just apply to some outside fund for, but something that they see a path forward for which outside technical and financial support are keys to achieving their goals. Thanks.
Great, thanks, Ambassador Kolker.
I think the next question is for Ms. Pompey-Sidar. So we know that there's a $33.3 billion annual funding gap in reproductive, maternal, and newborn adolescent health. And obviously, at the very beginning, we described the Merck for Mothers initiative and the amount of money that's been dedicated to this. I wonder if you could comment on how we can leverage further private capital to do good ethically and sustainably in this area.
Thank you for the question, and thank you for inviting me. Yes, we feel that to achieve the sustainable development goals and maternal health goals in particular, the private sector has a role to play beyond just bringing in funds and philanthropy. So private sector is here to bring in expertise together with some innovations to align with country priorities, to try out solutions, rapid prototype solutions, fail fast, and provide some of these solutions to the countries at scale. We believe that there is need for commercial capital to join hands with government and philanthropy capital to make some of these solutions, to take them to the market, to create markets for some of these solutions. And that's the only way we can sustain some of these goals. It's really about creating the blueprint of solutions and sustaining them, scaling them over time. And that is how we feel that we can make care affordable across the various segments of the society. And in low and middle income countries, that's a huge problem. There may be very good care available, like it's available in India, but not necessarily many can afford it. So affordability and quality remain the core pillar that we work on. Thank you.
Thanks, Pompey. Now I'd like to ask Daryl Jung from the International Finance Corporation to kind of introduce the role of institutions like the International Finance Corporation in addressing an issue like global surgery. Daryl?
Yes, thank you. First, let me explain IFC versus World Bank. People don't know the difference. I'd like to explain that IFC is a company of the World Bank. World Bank would work with governments. IFC works with private sector, okay? So we are part of the World Bank group, but we work with private sector. That's very important because private sector in so many of these solutions for the world drives. It's the key. It's the king. The private sector, I've heard some of you talk about it already, but it brings innovation. It brings entrepreneurship. It brings that balance of risk and reward. And so IFC is charged with basically working with private sector. I will tell you that IFC is actually a very interesting organization that we could be very well positioned to support global surgery and its plans. I will tell you that IFC is probably the greatest investor that no one's ever heard of. Year in, year out, we invest upwards of $30 billion US, 30 billion in 1 year across 109 markets. We don't brag about it. If we were a Wall Street group, we'd be on every paper. We're very quiet. We make our investments. We make them with private sector. We look for programs, platforms, scalability. So your question, Doctor, was how would maybe IFC look at it? We would look at this, I think, create some type of program that is clearly scalable. You will have IFC's keen interest in that. If it's framed as kind of a one-off deal, this is not, but if it's framed as a one-off deal, that's probably better for somebody else to look at. Okay, so I'll stop there.
Thank you, Daryl. I think a lot of us are probably salivating when we hear $30 billion. But I think that's great to think of, beyond an individual one-off. So, Izzy?
Thank you very much for sharing that. And I really like that focus on the scalability and not a one-off solution. I think that's a perfect segue to the next question for Shan. So I came across a very interesting quote from you, Shan, and you described impact as being grounded in people and the environment that we strive to serve. And I wonder whether you could speak to how innovative financing and funders can apply this ideology to their strategy, specifically for surgical systems.
Thank you, Izzy. So let me kind of set one macro point before I jump into this. To put things in the broader context and building on Daryl's point, if we look at the global financial markets, right now there's about $90+ trillion globally in assets, out of which, interestingly, there's been a monumental rise from zero to now $23 trillion in assets asset owners who are signatories to the UNPRI. The reason I provide that broader frame is that provides some context is in terms of what we're actually looking at is really a plumbing problem, right? And why I say a plumbing problem, there are these investable assets that are out there in the markets. The challenge in building on what Daryl said is we need the investable structures to allow that flow of capital to come in to ultimately strengthen the global surgery sector, and importantly, to expand the fiscal space for these interventions, right? And when I dive deep into some of the NSOAPs, we've looked at one in sub-Saharan Africa, for example, what immediately presents itself is certainly impact investment in the private sector is not in and of itself a silver bullet, a panacea, but what it is a lever to pull in addition to the other levers we have out there, right? Where ultimately might allow for even task shifting to allow ODA to really be used in the uninvestable segments, while then directing private capital into the investable aspects of these NSOAPs. And what I thought might be useful, Izzy, is I might touch on two specific aspects. So one of these is the work we've been doing in outcomes-based financing, right? Where if I looked at the basic premise between outcomes-based financing, where there are certain downstream costs, contingent liabilities that flow when we're unable to prevent conditions early, the early management of these, whether it's things like cervical cancer screening, whether it's better management of antenatal care to prevent complications in childbirth, right? Whether it's preeclampsia and other things, whether it's things like financing upfront investment to laparoscopic surgery to then reduce complication hospitalization times downstream to increase capacity utilization at tertiary care facilities. What can happen is that dollar invested today could well prevent 2 to 3 or potentially more dollars downstream. The challenge is right now, we don't have the financial structures actually allowing for the capture of those downstream savings and those returns. And it's not a journey that happens overnight, but fortunately, we're on a path that's built momentum. Where if I looked at the outcomes-based financing universe to date, there was 0 of these deals funded in 2009. And now, I believe at latest count by Brookings, there's 441 million in projects that are being funded in over 30 countries around the world, and both across LMICs as well as high-income countries. And so that approach, I think, has particular promise in the work we're doing. But of course, it's not the only instrument, right? The other thing we've seen that's particularly interesting is the right matching of capital, right? Where often when we look at, unfortunately, I hate to say, and Pompey touched on this earlier, right? Where we look at a country like India, where often there's there's potentially high quality of care, but it's unaffordable. If we actually wire that back, often it actually comes in the capital structure, where if, say, for example, you have private equity as a core investment into, say, tertiary care, it can sometimes be rate limiting in the affordability downstream because you've got to hit a 20% IRR and a 5 to 7 year exit horizon. One thing we've been looking at with governments both in Asia, sub-Saharan Africa, is looking at infrastructure financing as a model for healthcare, where often the longer horizons of 10 to 20 years allows for a lower annual repayment and therefore stretches out that horizon to improve affordability of care. In the way we've seen the explosion of infrastructure like toll roads, ports, airports, etc., what COVID-19 has shown us is how critical health infrastructure is for economic growth, as well as, most importantly, the well-being of people on the planet. But I'll pause there and happy to dive into any later, Izzy.
Thanks, Sean. That's like to turn it over to Ian Walker, our speaker from Johnson & Johnson, just thinking about, what is the role of the private sector and how does the private sector evaluate all these investment opportunities around something like global surgery? Ian?
Well, thank you, everyone. And as Darrell and Pompey both said, the private sector is hugely important to the success in this whole drive towards surgery in low-middle income countries and adoption of NSOAPs. Many of the private companies do have foundations, and these foundations do provide funding, but mainly to programming. What we probably would not get involved in is anything related to build. So we get asked, could you build us a hospital? Could you build us a clinic? These things we wouldn't get involved in, but what we would get involved in is looking at programming. So how do you access and how do you actually, what sort of things do we look for when we get a request from a program? Well, first of all, these programs really need to be aligned to the corporation's strategic intents. So if, for example, we say we're going to be looking at long bone fractures and obstetric fistula, then you probably won't get very far in a conversation about hernia, for example, or other forms of cardiac surgery. If our focus, we've said we're going to be looking at fractures and fistula. Also, so you need to look at saying, what is the strategic direction of the corporation and how can I access that? Because that makes a much easier conversation. And what also we look for, and it has been mentioned here before, is I really look for 4 areas. The first area, it needs to be sustainable. I think the comment was made previously, anybody could do something for a year. Anybody could be a hero for a year. The real challenge is how do you do that for 2 years, 5 years, 10 years? And when you get that sustainable piece, that's when it gets embedded into normal structures within a Ministry of Health, within a country. The second point is, can the program be scalable? If you take it from a small beginning and it provides a proof of concept and it is proven to work, can you scale it? And then can you say, is it actually repeatable? Can you transfer it to a different region, to a different country within Africa? And finally, because we're corporate, one of the things that really is to the forefront is measurement. Measurement and evaluation is crucial to us. And let me give you just a little anecdote on that. I get so many requests from people to say, looking for support for programming. And I say, okay, well, why should I support you? And they say, because I'm really passionate about this subject. Well, I'm sorry, this is the tough message. This is tough message number 1. Passion is no substitute for planning. Because when you look at an application form, it needs to be sustainable, scalable, repeatable, transferable. And when you add passion in there as the secret sauce, that's when it can really, really come to life. But if you lead with a conversation to say, I'm really passionate about this subject, therefore, please give me some money, it's probably not going to get very far. It needs to have more foundation than that. And the other area where we've changed and where we've pivoted slightly is that historically, certainly within Johnson & Johnson, we've really focused on surgeon training. There's been a realization that safe delivery of surgery, and this is crucial to the NSOAP as well, involves other actors within an operating room. So the anaesthetist, the OR nurse, the community health worker, these are all important people, even the operating room manager, these are all important people to safe delivery of surgery. And we are taking a much more holistic approach. But really, just to finish, the key message is, look at your alignment, your objective, your partnership objectives, and say, how does that fit with a corporate? And I'm not just talking about J&G here, I'm talking about all different types of corporations here. How does it fit with the strategic direction of a corporation And is that going to make an easier conversation, or am I going to be pushing water uphill with this corporation because it's not really what they do?
Thanks, Ian. I like that. Before we introduce our last speaker, I also wanted to acknowledge the support of Dr. Key Park from the Harvard Program for Global Surgery and Social Change, who's been a big supporter of this webinar series and our talk today. Thanks, Izzy.
Thank you very much for that, Ian. I really like what you said. Passion is absolutely no substitute for planning. And I really like that 4-point framework you've provided, which I think in some ways summarizes what previous speakers have said. And I think a perfect segue to our next panelist, Dr. Jeff Evertson, with regards to the Global Surgery Foundation. I wonder if you could comment on what you feel the GSF's role is, and especially in response to some of the points that Ian has just mentioned.
Thanks, Izzy, and what a wonderful discussion this is, because we're getting so many different angles on the funding question. This is fantastic. You know, when I helped start the GSF several years ago and the concept started to slowly grow, what we realized was that there were many great organizations doing great projects, getting some funding, but it was pretty fragmented. And looking at the world, the global impact of what the Global Fund did for HIV, TB, and malaria sets the stage for a model of collaboration, of partnership. And so within the UN context, we wanted to try to build something unique for surgical care. And when I say surgical care, it's exactly like what Ian just said. It's not just the surgeons, but it's the nurses, the anesthetists, the whole surgical team, the people who are getting the equipment, sterilizing the equipment. Everybody involved with surgical care has to be considered part of the team. And so as we look at that, how do we upscale capacity? We've seen through organizations like the Global Fund, like Gavi, that when we consolidate under a neutral, common platform to achieve those attributes, which all of our speakers have talked about today, scalability, repeatability, you know, these measurability, these are the things that a global fund for surgery can do. And so that's what the strategy for the Global Surgery Foundation is beginning to go forward with. And that's what our role, we feel our role is to be that common platform. And I've said this many times before in other webinars and other discussions, that we want the global surgery community, including all of those specialties, anesthesia, nursing, we want them to feel that the global surgery platform of the GSF is their platform to come together on. And so it just makes sense that a consolidated common funding pooled will then help build the progress forward. And one of the questions that came in was, how do you foresee balance between reassuring funding bodies' effectiveness and accountability? And I think that having a mechanism built into a common platform for measurability, like Ian said, outcome measures is going to be very, very important. A great plan. So when we come together on a common platform, we can achieve these things in a stronger way. And so that's the essence of what the GSF wants to do and intends to do.
Thank you, Jeff. I think that's a great way to kind of wrap up some of what we've heard. A lot of different funding options, but we do need a common platform, as Daryl said, and all have said, like investing in these one-offs is not sustainable and probably not replicable and not measurable. But how do we, looking at the questions that have come in, and this is for anyone, how do we link then what's happening at a country level with the, you know, careful development of a national plan for surgery, anesthesia, obstetrics? How do we then link that to these broader funding opportunities? Daryl, you want to take a stab at that?
Yes, sorry, I was on mute. Listen, I will tell you that IFC supports development impact, but we support. We generally don't lead, meaning we'll support a developer or an entrepreneur. He has an idea, he has a plan. It's exciting, it's replicable, it's scalable. We'll support him. We'll support him with debt and or equity. We'll support them across markets. But when you say, how do you start? Actually, I think you need to start with bringing in and enticing private sector. You have to open it up to private sector, because a lot of these other funders, they're donors, they're philanthropists. I mean, that's all great, but none of that's actually sustainable in the long run. The funds will run out. You need the entrepreneurship of a private sector investor to actually grow that business. And I've been working with Sean on some ideas on different things, but you have to create the opportunity. Investors invest. That's what they do, and they're always looking for ideas. So I think the big job is to come up with an investable concept. The idea of providing equity, I'm talking social equity for global surgery, brilliant. But somehow we got to create it into something like somebody can just say, that part of the business I can do, or that part of the business, if I invest, I'll bring IFC in and I can make a go of it. So I'm saying somehow it takes a leader, a private sector leader, and is it in one country, or is it a global, big company that says, look, I'll take it on, but it takes somebody to start. And either there's somebody out there that's already angling for this, or sometimes we can all convene ourselves and actually go approach, a singular start person or start group. I'll stop there.
Thanks, Daryl. So
can I just come in the back of that?
Go ahead, Ian, sorry.
Yeah, just on the back of that, one thing just to add to that private sector do bring, because we do this every day in the office, is focus. I think if you really keep focused and you keep what you can achieve possible, then it's much more convincing to a private investor. If you come in and say, Africa has a huge amount of problems, we're going to try and solve Africa, then that's going to be a tough conversation to have with Daryl or Shan, because they're not going to be that interested. But if you say keep it tight and keep it in a focus area, and even maybe go after one intervention area. Now that's a tough conversation, which means you have to say no to other people. But by giving focus, you can then really target your investor as well, who, again, to my point earlier, has a strategic interest in that area. And that, by keeping that focus and keeping it tight, you're more likely to get a positive response.
May I jump in quickly, Laura? Or did you want to move to the next question?
Go ahead, please.
So one thing I'd love to add on to Daryl and Ian, and to give a lot of our audience a kind of practical takeaway from this, a lot of the starting point of this action is really thinking in a very focused way on the actual value that's created, where that's realized, right? Is that realized by the government? Is it realized by individual citizens? Is it realized by health systems? And then thinking about how are the costs and benefits of that currently borne, and what are ways to restructure that? Because often what we've seen, especially in LMICs, is actually that there's this distorted split of currently where the costs are borne, where the gaps are, and that mismatch sometimes leads to the lack of an investable opportunity. And what we find our role often is actually diving into the weeds of it, so going out to villages, understanding what the challenges are on the ground, where the gaps are, where the value is being realized, and then tying back to see where that can create economic value to create an investment. Now, why I say economic value? If it's an investment, there has to be some sort of economic value. This, of course, doesn't preclude donor funding, right? Direct, philanthropic, non-profit generating. But within this universe, that becomes key, and that often requires taking a systems thinking approach where there are often cross-cutting solutions across. So I'll give you one example. In one of the states in India where I'm currently working with state government on a sort of $100 million statewide program, in that case, what we've actually realized is often the opportunities for early cancer screening could be dovetailed with NCD management, right, on the front lines and linking with AI solutions. But I bring that up because often network systems need to realize actually there's multiple value points that can be created with the one intervention that can then be tied back in. Now, taking that lens and applying it within global surgery, where I think the opportunity lies is thinking with a very focused view, because often a lot of the economic analysis is very top down, right? Where we take certain assumptions about X many people, Y many average costs equals Z amount. This kind of flips that on its head where we need to start thinking about, well, if we would roll this out in this area, this level, what are the fixed costs that go into it? Because sometimes we can prevent conditions, but actually you still have to keep the hospital running, right? So your fixed costs are locked in for effectively 10 years. So we can, amortize the cost out and say it's a sort of $100 billion global challenge. But what we need to think very hard about is where the economics actually ties in to a potential investment. And that's what we think, is important for people to think about on the ground as they start structuring these, but also where the opportunity really lies when we can dive into that and then create these programmatic opportunities that, that the type Daryl and me work on to ultimately fund to deliver impact on the ground to improve people's lives.
Thanks, Sean.
If I can, Sean, just to add on a question to what you've raised, because I absolutely agree, innovative financing is not a silver bullet, but how can impact investors ensure, balancing the interests of a good return on investment without putting further financial strain on the patients who are the most vulnerable in this circle?
Great question, Izzy. So once again, I think often in the past, right, PPPs in health have got quite a bad reputation, right? And that's because of not the instrument itself, but because of the way they've been structured. It'd be like saying, contracts for the sales of good or bad. Now, you might go and buy something from a shop and they sell you a dodgy battery and it doesn't work, but they might sell you one that works. So the problem isn't the actual contractual instrument. The problem is typically the people on either side of that contract. So I bring that up because now diving into this question about that equity, really, about what we're talking about here in terms of balancing the interests between the investors and the people benefiting from it, I think it comes down to the structure and alignment, right, within that. So if I use the example of, once again, going back to outcomes-based financing, within outcomes-based financing, what's interesting is the investor only makes money if health outcomes are improved that deliver savings to a health system. So the counterparties we're working with are typically government health systems, where a number of LMICs have started instituting state or nationwide health insurance programs, which are bearing the contingent liability. So by contracting with them to share in their downstream savings, you're then able to monetize that. And ultimately that adds zero costs to the individual on the ground, right? So that's one approach. Does it always work? Not necessarily. You need the right conditions for that, right? In terms of coverage, access, and schemes in place. The other thing we've seen is in terms of health infrastructure financing, with the right approach, with the right sort of balance, sometimes you may need to blend these instruments, right? Where there can be a for-profit component and a concessionary position to make it affordable. But that's got to come from that sort of reverse analysis of actually looking at the cost per unit, cost per service provided, and then working backwards to the economics for both the investor and any donors you might need to bring in to make that work, right? And a lot of it honestly comes down to the discussions with the investors one-on-one to really bring that, right? And in some ways, creating optionality by ensuring there's a competitive process. So we often work with multiple institutional investors to get the best pricing. I mean, the final point I'll add is where we sit now in the global credit markets. I think cyclically, we're at a particularly opportune moment for the global surgery movement, where the credit markets where they are now, given by the macroeconomic conditions, provide an opportune moment where the cost of capital is particularly lower. And I expect will continue to be these levels over the next sort of 2 to 5 years, which then drops ultimately the cost of capital for a number of these interventions. And in many ways, emerging markets, where a lot of the MICs are located, become more attractive and counterpart with sort of slower growth, high income countries at a time like this.
Thank you very much for that response. Now, I don't mean to monopolize the discussion, Laura, but I think this would be a great point to bring Pompey into the conversation, Pompey. So I know Merck for Mothers is an outcome funding partner in the highly publicized UKRISH impact bond. And I know you've been working with the Foxy group with regards to the Mayanta certification since 2017. I wonder if you could describe some of the main reasons Merck for Mothers got involved with this and how it's performing and what lessons there are to be learned as well from a global surgery perspective.
Thank you for the question. So our work at MSD for Mothers is focused on improving the quality of private maternity care to ensure better health outcomes for women around the world. And we have a very deep presence in India. But as we heard, at times these programs remain programs, and once funding stops, the intervention does not continue. And we know that for India, to decline, to accelerate decline in maternal mortality, to achieve SDG goals, we do need to improve access to safer C-sections, plus good primary care, good ANC. So through the Utkrisht bond, our goal was to work in synergy towards leveraging and aligning our resources, financial, technical, stakeholder network, all of it, to achieve good quality at these private facilities, the local private providers, which are really complementing the public healthcare system in India, to build out a more resilient health system. And so in this process, through all our grants, we realized that there was lack of accountability, and that is not what we found. That's something that, us as a donor community we've seen it. So the impact bond does bring in a lot of accountability and measurability in the outcomes, and also brings a lot of cost efficiency. But our focus really was on sustaining this effort, and how can we actually have a longitudinal engagement with facilities in the long term, build a quality culture. And in that process, we thought about actually creating market for quality. And we actually now have about 1,200 hospitals who have paid up for quality improvement, which in itself is, it's the biggest quality improvement program anywhere in the world right now, and that too focused on maternal care. Through the Utkrisht bond, we saw that quality was indeed poor, and improving quality was not easy. There were rounds where despite all of this approach, the hospitals did not meet the standards. And that brought the focus back to the technical requirement. And therefore, this partnership with Foxy, where practicing doctors are actually helping contextualize these standards to India and ensure that these remain relevant and not just bookish. And so it's on one hand, this technical support that we continue to get. It's a community of local private providers through Foxy, through the peer-to-peer mentoring and supervision that they're doing this whole quality improvement. And through this financial instrument, we are ensuring that there is accountability, and indeed, we are able to measure the outcomes, and in terms of the number of lives. We've also seen that siloed interventions like training, like skilling, like accreditation does not really have lasting impact. And therefore, this whole transition to productizing quality is possible only when we demonstrated that we can improve quality at scale, create market, and that folks will be invested in this for the long term. So it's really been a fascinating journey for us. It's also kind of opened up, the eyes of the policymakers as to what's really missing. Why are women dying? What is the need for safer surgeries and safer C-sections? And how impactful safer C-sections can be in saving lives of mothers. Thank you.
Thank you, Pompi. I wish we had more than an hour. I knew when I saw the list of panelists that we could actually probably discuss this longer, and so many great questions have come in. Jeff, I think one question that I do want maybe all of us to tackle a little bit, thinking about the Global Surgery Foundation. Somebody asked, how does this new, what we think of as a global health initiative, link to those other successful global health initiatives like Gavi, like the Global Financing Facility at the World Bank, like the Global Fund for TB, AIDS, and Malaria? So we're talking about a new funding mechanism. What are the links? And thinking about also, as Ambassador Kolker said, the bulk of funding still comes from bilateral funding for many for low middle income countries. So how does all this innovation of the private sector, and yet this backbone of kind of government funding fit together under an umbrella like the Global Surgery Foundation?
Well, that's a great question, and I'm not sure I have the perfect answer, but one of the things that we're looking at is through partnerships, and that's partnerships with organizations like the WHO. We can come together with industry and other investors and then go to governments and say, look, we're starting, please join. You get this threshold, and that's what takes it to the next level. And this includes the GFF. And there's some points made earlier about focus. I think Ian and Sean and Daryl talked about this focus. You know, when we, and I've heard this from lots of investors and people that I've talked to, the global surgery as a whole is too broad and too complex for them to wrap their heads around. And as much as we don't like silos, funding silos is clean and much easier than funding a broad spectrum approach. And so what we've done with our strategy is we've identified certain, what we're calling entry points, but you could call them whatever you want, focus points, one of them being maternal health and C-sections. And if we can help build capacity in that particular focus area, that particular entry point, you build the surgical capacity using the tool that we have with the NSOAP, getting all the partners together, including governments, the government that you're trying to help, and other governments wanting to help, industry, World Bank financing, everybody comes together, we can focus on that. Now, the beauty of doing that is that when you build capacity for C-sections, as an example, that same capacity is going to treat an open fracture, an appendicitis, a bowel obstruction, an emergency trauma. And so the massive spillover is incredible. And there was some work done in Nepal, which I should mention, where there is an organization doing some work on training nurse anesthetists. And the funding, when the plan was all looked at, the funding agency came back and said, well, it's too expensive per life saved to train a nurse anesthetist. And what they didn't factor in was this massive spillover, because they were focusing on one particular aspect of lives saved for, let's say, safe motherhood. But what they didn't factor in is that same anesthetist would treat everybody in that community. And when they factored that in, it was like, oh my goodness, this is one of the best investments we've ever seen. And so this is the beauty of surgical care. It serves as the foundation for strengthening the entire system for the entire age span, and it impacts the whole healthcare system. So as we aim for universal health coverage, really surgical care is one of the best investments that you can do. And if we target a specific entry point like maternal health, and even more focused C-sections, or one of the other targets, entry points that we're aiming at is cervical cancer. If we can have capacity built up in that area, we're going to impact the entire healthcare system. And so the Global Surgery Foundation, going back to your, that's a long description of going back to your question, in terms of the pooled funding and the other big agencies, I think that if we follow that model and have these discussions with them, not only are they going to want to get involved, but I think the governments are going to want to get involved when we build that case. And just as a note, we're starting a strategic financing modeling group within the GSF, bringing on experts in the field and former Global Fund people, and we're really quite excited about moving it to the next level. And we're at that threshold of moving it to the next level right now. So stay tuned, and I hope we have exciting news in the near future.
Thanks, Jeff.
Thank you very much, Jeff, for providing that perspective with regards to the pooling, allocating, and measuring of impact of these potential funds. So as we draw to a close, I think it would be good to wrap up with a quick rapid question round. So we'd like to ask each of our panelists, so from your perspective, be that government or industry or philanthropy, corporate, what is the one thing that ministries of health, health professionals, advocates for global surgery should do to make their investment case stronger if they were approaching you?
Well, I'll start and go in the order of the panelists. First, we don't need a scientific breakthrough or some new way of doing business in order to achieve much scaled up coverage for surgery. This is something we know how to do. And in rich countries, and even for rich people in poor countries, high quality surgery is available. It's a moral obligation of the global community, as well as the stakeholders in each individual country, to see that this access is broadened dramatically. We know how to do this. It is not a question, as I say, of discovering something we don't already know. We need to implement what we already know how to do, and that should make the task much more able to be defined and achieved.
Well, I'm going to cheat a little bit because I'm going to answer the question with two things. The first point, I think I made the point earlier, is really keep focused. That's going to keep things an awful lot tighter. But the second thing is really around innovation and engagement with the private sector. I think it was Darrell that mentioned the role of innovation. And we think about innovation, certainly in my mind and many people's mind, you think about as a product. We're going to invent a new widget that's going to solve a clinical or a surgical condition. It's going to be a medical device. It's going to be a drug. That's a form of innovation. But the ministries of health need to understand that innovation is much broader than that. Innovation in supply chain, to me, is one of the key things. If you're in a district hospital up country in Kenya or in Ethiopia or in Ghana or wherever, how can you actually get that care delivered? The product may be available in Nairobi, but it can't physically get out to the districts where, let's face it, that's where the majority of people get their care. So what sort of innovations in supply chain can really be brought to the table? And that's, I'm sure there's people sitting on this call here who have got some great ideas about innovation in supply chain. Innovation is much broader than just the product. And that's where also, with a couple of the panelists, innovation in financing as well. What are the creative parts to innovation? What's new? If you do the same old, we're not going to get any change. And change is driven by innovation. So please don't think innovation means product alone, because that's not the case.
Can I just reinforce Ian's point? We have to solve that problem right now in terms of coronavirus vaccines and COVID countermeasures. These are today's problems. This isn't a theoretical issue.
Yeah, well, one of the things I saw yesterday was that the vaccines got to be transported at -80 degrees. There's your first challenge.
Absolutely. Sean, do you have your rapid fire round?
Absolutely. Building on both Ian and Ambassador Calker's points, it's very much taking a systems thinking approach, right? And that innovation, as Ian puts it rightly, can cut across financing, supply chains. And I think product, honestly, is probably the area where it's least needed right now. There is still some scope for it, but it's really the systemic approach we need to take in addressing this. I think that's the biggest gap we face right now. And that thinking from first principles and allows for the creation of programmatic systemic investments that are the type me and Darrell can put sort of institutional capital to work on, and would love to collaborate with the global surgery community as we try to move that forward.
I'll jump in. I think I would tell the government, look, present the program, you'll get people excited, but actually work ahead of time and create a project, something tangible, something bite-sized, something that's focused. I mean, we've all said this, and the private sector, they will take it. If it's too broad, it's not tangible. They like to see something that they could stick their money in and they can actually see how they can actually make money off it. So, you know, create a little bit of a project. It could be building blocks, because you will get investors excited, because money is out there. Sean will tell you. I mean, him and I work in the institutional market. There is billions and billions and billions. They're all looking for places to put it. So we just have to, the governments just have to help create the environment and the little project for them to put their money in. There you go.
Great. Pompey, any last thoughts?
So I think, going forward, to have a lasting and a sort of a solution to all the issues that we're facing, and to be really able to meet sustainable goals, we feel we require a blended financing approach, where we can actually blend these different types of capital and where we can kind of really bring in all these innovations and actually help the government embed some of these solutions into the health system. And the blended financing facility should therefore, the commercial bit should work at commercial terms, and the philanthropy should work at those terms, bringing in more and more innovation. And that's where I think the private sector really has a role to play.
Right. I think, Jeff, you have the last rapid fire response.
Well, thanks, Laura. And I just find it fascinating that here we are with representation from all the different sectors of funding for global health initiatives like global surgery. And I think this is representative of what is actually needed. We need to all come together, not be as fragmented, and do it together. And really, as Ambassador Kolker has said, the government funding, both recipient governments, they have funding oftentimes in their accounts that they can put towards things, but they need a little bit of a stimulus. So a stimulus coming from philanthropy, industry, and other sources is sometimes all that's really needed. But I think that to kickstart the process of funding a plan, implementation, and then seeing the results coming back to show proof of concept, we have to show proof of concept of these plans. Then it's a no-brainer when you really think of it, because when we invest, it's a good business plan for industry, because what's going to happen is when you have a healthy population that has access to a good healthcare system, they're going to be more productive and they're going to do better for their economy. And that's a great business plan. More of the materials are going to be purchased. More of the economy is going to grow. So it is a good business plan for industry. It's a good business plan for governments, and all around. It's bringing the plan to fruition and measuring impact to show that it actually works is what is needed. So yeah, I'll finish with that and let you close out, and then I'll say my last words for Unitar.
Thank you, Jeff. Wow, what a great discussion with so many different perspectives. I think as everyone participating, we have many more questions that we weren't able to address. So I think those of you who are at the country level, especially working on an NSOAP or have an NSOAP, I hope this discussion gets you excited and thinking about all the different options, of really ensuring that your plan is sustainable, replicable, scalable, and measurable. Because without that, all of these funds that we've talked about, you really can't access them. So I hope it inspires that NSOAP planning at the country level. As Ian said, we all have the passion. We all have the secret sauce. And it's great, and it's inspiring to talk to other people who have that secret sauce. But we also have to do like the nitty gritty work of really breaking this down and showing the impact, and working with economists and health workforce specialists and service delivery specialists and innovators, and really pull it all together. I think one common theme we've talked about a lot is it really needs a systems thinking approach. And just a reminder that the NSOAPs are built on those 6 building blocks of a health system that was defined by WHO. So by reinforcing, infrastructure, medicines, all of that, you know, medical innovations along with health workforce issues, which have come up several times. What are those service delivery mechanisms that might be innovative and different? How is governance managed at a country level? Country leadership, governance, political will. It really has to be that country-driven approach. And then finally, the sixth building block is what we've been talking about today, which is financing. You know, without financing, the rest of it just doesn't hold together. So I'll turn it over to you, Jeff, and just thank everyone. And we're noting all the questions and we'll try to get back to them maybe in a future discussion. This has been really inspiring for me and motivating, because the work doesn't happen while we're all talking about it. The work happens, you know, by individuals all working together to make it happen. So thank you for the opportunity. And thanks to all the panelists once again.
Thank you, Laura.
Well, thank you,
everyone.
Laura and Izioma, for moderating. Great job. And this has been a wonderful discussion. I really want to thank all of my co-panelists for this topic and discussion. It's been very, very good. And I just want to say a special thank you to J&J and G4 Alliance for sponsoring this. J&J is sponsoring the entire series, and we really appreciate that support moving it forward. And of course, the program in global surgery and social change, we're very, very thankful for our partner as Unitar with them. And Key, thank you for being on the call and being part of that. So yeah, just to wrap it up, I think the points that I'm thinking is that partnerships, doing this together, is going to make a bigger impact. Focusing, having scalability, having it measured, and of course, never forgetting our passion, but that passion is there. But we need to have those facets of a good plan to move it forward. And I really encourage all of you listening to work hard at that. And we're here as a UN platform to try to help. This is number 4 of 7. So we have a few more series, and the next one is in 2 weeks. So keep tuned. If you've registered for this one, you will automatically get a reminder email for the upcoming webinars, and we would love to have you as part of them. So on behalf of all of our sponsors, the United Nations Institute for Training and Research and the Global Surgery Foundation, we really want to thank you as the speakers and all the attendees that joined us. And I hope you have a safe week and a good day wherever you are in the world. Thank you very much. Goodbye.
Thank you all.
Thank you very much.